Hello, thank you for joining. We'll just give everyone another couple moments. All right, thank you for joining, everyone. Ed, would you like to kick us off? Oops.
Always have to remember that I was on mute. Hi, everyone. I'm Ed Bites. I'm a partner in the healthcare group here at White & Williams. When I say here, I'm actually in my home in Collingswood, New Jersey, coming to you through the magic of Zoom. This is our MEDx Talks program, a different version of it. Normally, this is something we try to do every 2 years in person. It's a series of high-level presentations on cutting-edge topics impacting the healthcare industry. I sure hope that once we're on the other side of the COVID rainbow, we can all see each other again in person and catch up. But I'm very excited to be here together today, virtually, with our three esteemed guests. And I'd like to just quickly introduce our speakers and then do a little bit more about each of them before they speak. But for those of you who haven't done this before, MEDx Talks is a series of presentations, just kind of the meat, as much as you can get across in 15 to 20 minutes on an idea, something to spark a conversation, something to help you get thinking. And I said this the past couple of times that we've done this, that some of the best analogies, creative ideas that I think I've had in my cases often come from things, just whether it's a complex idea about medicine, the difficulties and challenges we face. Some of the best ideas I have come from things I've heard people say during MEDx Talk. So just very briefly, before I introduce our speakers, I just want to acknowledge the chair of the healthcare department at White & Williams, my partner, older brother figure for the past 14 years of my life, Kevin Catone, guy that interviewed me and the reason I have a job. So Kevin, if you just want to wave and say hello to the people. There we are. So without further ado, I'm going to introduce our speakers. Very lucky and happy to have with us today Dr. Eric Newman, who's the Director of Quality Innovation at Geisinger Medical Center. I'll get back in a minute to what he's here to illuminate for us, although I will say that Director of Innovation is a title I'm trying to adopt around the house, getting my kids and wife to call me that. It hasn't taken off yet. We have Dr. Evelina Graver, who's an attending cardiologist and the Director of the Coronary Care Unit, a specialized cardiac unit that treats patients with acute heart conditions in New York. And lastly, we have Betty McNee, RN, NHA. She's a senior clinical risk specialist consultant in the Graham Company Safety Services Department. And she's going to talk a little bit about some of the challenges that are facing the nursing home industry that were there before COVID and are going to be around, if anything, exacerbated by our current situation. So before we're going to get right into it, Dr. Eric Newman is up first. He's as I said, he's a Director of Innovation and Quality at Geisinger Medical Center, board certified fellowship trained rheumatologist. In addition to general rheumatology, clinical interests include rheumatoid arthritis, patient reported outcomes, quality improvement, process redesign, and value-based care. And those latter points are really what he's here to illuminate for us with some reporting on the successes Geisinger has had with their Ask a Doc program. So without further ado, I will introduce to you Dr. Eric Newman.
Well, thank you, Ed, and thanks for the opportunity to speak with you today about our novel communication program called Ask a Doc. Again, I'm Eric Newman, Director of Innovation at the Medicine Institute at Geisinger. And though I'm a rheumatologist by training, I'm probably a frustrated engineer by brain hardwiring, much to my wife's chagrin. I've spent my career at Geisinger building new programs of care, and this is one of the most successful, embedded, and gratifying projects to date. So I want to cover a few basic areas with you today. I'll briefly review how this whole process started, discuss a little bit about our journey, summarize where we are today, and then finally focus on the ingredients that's led to this program's success. So let's start with how this whole process began. It was about 2010. At that point, Geisinger had fully embraced the patient-centered medical home model, which is a care model where the patient's treatment is coordinated through their primary care team close to home. However, in that model, there's very little definition about what role a specialist should play. So I was assigned by our then CEO, Glenn Steele, to lead a work group to figure out how to successfully integrate primary care and specialty care providers. I figured when I was done with this, that I could move on to fixing something a little bit simpler like world peace. So we began by setting a problem statement as follows. How can we successfully integrate specialty care with the patient-centered medical home to improve quality, improve efficiency, and reduce costs for the population we serve? Or as I like to think about it, how can we get physicians to be in the same river, the same boat, and God forbid, actually rowing in the same direction? Well, instead of proposing solutions, we began by trying to understand the problem. We mapped the usual care process that happens between primary care and specialty care as follows. A primary care team member would see a patient and decide at some point that they might need a consult from a specialist. They place the consult, and sometime between 2 weeks and the 12th of never, the patient would eventually be seen by the specialist. A specialty care plan was set, and from there, two pathways existed. The first pathway was consult only, with the patient returning back to primary care. The second pathway was the patient receiving ongoing specialty care. And by mapping this care process between primary and specialty care, we identified 4 areas ripe for process improvement. These 4 areas were the following. First, the trigger for specialty care. Why and when did a provider decide that they needed help? Number 2, the mode of care chosen. In most cases, it's wait 2 months and drive 2 hours to see me for a face-to-face visit. Third, what's the care pathway chosen by the specialist? 3 different specialists, 27 different ways to handle the exact same problem. And 4, finally, communication expectations. How, when, and with what tools do we pass information from one person to another? We then set up pilots to explore and understand each of these potential areas for improvement. These last 2 areas, communication and modes of care, we combined into a single pilot. So for this communication and modes of care pilot, we conducted a study to determine the volume of communication between primary and specialty care, the effectiveness of that communication, and ultimately the cost associated with communicating back and forth. We used 1 primary care site in Frackville, Pennsylvania, and 2 specialty sites, rheumatology and pulmonary medicine. We collected data over a 5-day period of all communications from specialty to primary care office, and from primary care office back to specialty office. All staff from these groups were involved in the collection, including providers, nurses, secretaries, and front desk staff. Patient communications were excluded. We used inexpensive old school methods of data collection, basically clipboards and timers. When we got our results of the study, nobody believed them. So we repeated the exact same study 1 more time and literally got within 5% of our original evaluation. And here's what we found. In terms of volume of communication, about 16% of the communications that primary care sent outbound were FYIs. That is, there was nothing to do. However, on the specialty side, 77% of the communications back to primary care were FYIs. That is, I saw your patient, have a nice day, smiley face emoticon. We estimated based on this pilot that our system at that point in time was sending back and forth between primary and specialty care over 250,000 FYI communications per year. So with that much noise, how can you find the signal? In terms of effectiveness, we looked at the native tools in the electronic health record for communication, where a question was asked of a specialty by primary care. The failure rate was 25%. And finally, we calculated cost. We were able to record the time it took for the process of primary and specialty care to primary care communication during that 5-day period. We then multiplied the time by the respective salaries of the people involved to come up with a cost of communication. To account for differences in clinic sizes, we divided the cost by the number of clinic visits during that same period, which would give us a cost of communication for a primary care visit and a cost of communication per specialty visit. The results showed that primary care spent an average of $3 of human expense per visit in communicating with specialists, but specialists spent over $33 per visit in communicating with primary care. The system-wide expense was then estimated to be many, many, many millions of dollars. So, to summarize that, put that all together, we found that our existing communication process was extremely high volume, mostly noise, making the signal hard to find, ineffective, and expensive. And as one of my partners was fond of saying, other than that, Mrs. Lincoln, how was the play? So that's communication. From a modes of care perspective, we know that access in most specialties is problematic. Additionally, having all specialty questions answered using a single modality, a face-to-face visit, is wasteful in the sense that there's other ways we can provide help to our colleagues and their patients with our cognitive expertise. So to solve the care communication and mode of care problem, we developed a program we called Ask a Doc. Ask a Doc is an asynchronous communication process, and it allows a provider to ask a question of a specialist and have that question answered reliably in the time frame requested, always with electronic health record documentation. Now, Ask a Doc helps with what I call the brackets of care. So on the left bracket side, it helps avoid face-to-face visits for questions that could be answered with a simple review. And on the right bracket side, it allows patients that are recognized by the specialist to be sicker than thought to be seen sooner, and provide, if you will, granularity or another choice in the care delivery process. So how does Ask a Doc work? Well, we provided access to the Ask a Doc tool all throughout the electronic health record. So whether the provider is in an office visit encounter, a telephone encounter, an in-basket test result, they can access Ask a Doc with a single click. After clicking that link, the asker is presented with a choice of specialties. After they select the specialty they want, a form opens up, which is pre-filled with their information, the patient's information, and the Ask a Doc on-call provider for that specialty. The asker only needs to complete 3 things. Do they want a chart review or a phone call? Do they want a turnaround time of 1 business day or 3 business days? And what's the question that they would like us to address? There's also an optional function to submit an image if desired. They submit the form, the information is processed and sent back into the electronic health record for the on-call specialist in a specific in-basket we built called Ask a Doc. This in-basket is dynamic. It only appears if there's an Ask a Doc console present for that specialist, and it's all signal, no noise. The on-call specialist then selects the console, reviews the question, formulates the answer, documents using a highly structured template, and routes the answer back to the requesting provider. The entire process is tracked from start to finish. If the specialist does everything correctly, meets or exceeds the requested time frame, uses the correct documentation tool, and routes it back to the person that asked the question, they're given RVU credits for their work effort. There's no charge to the patient for this service. So that's how the program came to be. Now let's talk for a few minutes about our journey with Ask a Doc. We developed the software and the process in 2012, and over the next year ran through a series of pilots using a number of different primary care sites and those same 2 specialty sites, rheumatology and pulmonary medicine. An in-depth evaluation of these pilots showed considerable improvements in care delivery. Access to care improved by 35%. Provider efficiency of care improved by 36%. And reduction in expense per consult was reduced by 44%. This striking improvement on a small scale is what got us system leadership approval to systematize the Ask a Doc program. Our formal go live was in 2014, so we've been running this program continuously over the past 7 years. As each year has gone by, we've added and improved functionality in the software, adjusted the program to the needs of the end users, and continuously expanded the asker and answer groups. We've also expanded the program on a limited specialty basis to the inpatient side, servicing 12 different hospital platforms. So, where are we today with the Ask a Doc program? Well, here's a few of our current program vital signs. 86% of all Geisinger primary care physicians use Ask a Doc on a regular basis, making it the second most commonly used piece of software at Geisinger other than our electronic health record. We have 53 different specialty groups that are participating, including medicine, surgery, pediatrics, women's health, and diagnostic services. We've added some unique specialty departments, including genetics, pharmacogenomics, and gender medicine. Ask a Doc consults accounts for 12% of all participating specialty referrals. And this varies a little from department to department, excuse me, with infectious disease being the highest. There, Ask a Doc accounts for well over 50% of ID consults. Since our program's inception, we've received over 40,000 Ask a Doc consults. Our current run rate is over 14,000 Ask a Doc consults per year. The average Ask a Doc consult takes less than 8 minutes to complete. 99.9% of those 40,000 Ask a Doc questions have been answered. 98% of them have been answered within the requested time frame. And while the average requested turnaround time from our colleagues was 58 hours, the actual turnaround time was less than 8 hours. 93% of the time, the specialist answered the consult with all 3 parameters done correctly: time frame, correct documentation, and correct routing. In terms of outcomes, Ask a Doc has opened up more than 6,500 new patient specialty slots in 2020. Time to be seen has improved dramatically. Instead of a 2 to 8 week wait time to see a specialist, patients can often have their problems addressed in less than a day, often hours. And we have peer-reviewed published data that demonstrates a significant cost savings to our health plan based on decreased utilization. In terms of provider satisfaction, we've implemented a star rating system, allowing the asker to rate the answer they receive from the specialist from 1 to 5 stars, as well as an optional comments box that they can type in. We have almost 4,000 ratings to date, with an average star rating of 4.9 stars. Only 1.9% of all of our ratings are 1 or 2 stars. If a provider receives a 5-star rating and positive comments that were typed in, we send this information directly to the provider and their director as a way of praising their service and care excellence. If any provider receives 2 or more 1-star ratings in any quarter, we also reach out to that provider and their director after reviewing the encounter to engage them in improving the quality of their consultative reply. And while it's not scientific, we have a number of anecdotes from our primary care colleagues around, many of these are around how this program has significantly benefited their patients, providing high quality, accelerated access to specialty care, allowing their patients to avoid a face-to-face visit, or to queue up that visit with all of the information needed by the specialist, leading to a much more empowered and patient-centered care. And I think the best comment came from one of our primary care docs early on in the program, where he sent me an email that simply said, "This Ask a Doc rocks." So we talked about the problem, we talked about the solution. Now let's talk about why this program and why this solution has been so successful. First off, we followed basic problem-solving best practice. We started this journey not by proposing a solution, but by first trying to understand the problem to be solved. Too often in healthcare, we solve problems by forming committees that propose solutions without fully understanding the problem. We implement those solutions without measurement, which results in unanticipated and unmeasured adverse effects that happen when you play around in complex systems like healthcare. Second, we followed the wisdom established in the 1960s when all best things happened: the moon landing, Timothy Leary, and of course, ICD-8. But for us innovators, the best thing about the 1960s was Everett Rogers. Everett Rogers was a brilliant psychologist. He coined the term early adopter. And he wrote a seminal book back then called The Fusion of Innovation, where he outlined 5 characteristics that are critical when developing a new way of doing things if you want that new way to stick. And here's are the 5 characteristics. First, relative advantage. The new process had to be better than the old one. Second, trialability. The end users needed the chance to kick the tires and take the new process out for a spin. Third, compatibility. The new process had to work within the confines of the existing process and workflow. Fourth, observability. A project that was more visible and had more leadership support is more likely to be adopted. Otherwise, it might be considered the flavor of the week. And then fifth, finally, low complexity. A simpler process was more likely to win out over one that was highly complex. We tried to follow these 5 tenets in our program design and testing. As examples, we designed a system that was far more reliable than the previous system. So often in healthcare, we keep lists and track things manually and mentally because we're concerned that the event we want to have happen never happens. So by designing an exceedingly reliable system, a provider can ask a question and know 100% of the time that they're going to get a timely answer, which allows them to move on to the next issue with less stress, less anxiety, and more efficiency. Additionally, we listened to our end users. We actively solicited feedback from our end users and used that feedback to enhance the program's functionality. The end result is a program that keeps getting better, moving our user group from buy-in to engagement and ultimately to ownership. So, in summary, using the native electronic health record tools and traditional care delivery systems, care communication in healthcare is high volume, noisy, inefficient, and ineffective. To improve how primary care and specialty care integrate and communicate, we developed Ask a Doc, an asynchronous care communication process that's highly structured, highly reliable, and efficient. The Ask a Doc program resulted in a vast improved care communication process, has been well adopted over many years, and is viewed very favorably by the participating providers. It significantly improved access and quality of care while reducing cost of care. And finally, it's facilitated successful integration of our primary care and our specialty care providers. So I guess it's finally time for me to start working on world peace. Thanks for your time and interest. And after the next 2 speakers, if there's time, I'd be very happy to answer any questions.
Wow. Thank you very much, Dr. Newman. And I'm sure if the patients that have benefited from that process were here, they would thank you as well. It's just funny to me how many times the things that improve our lives on a daily basis, we don't know who the brain is behind them, and you know, to you and your team, just it's really deserve all the thanks for that. We just putting up a poll question now.
Yeah, Ed, not to cut you off, but
Yeah.
just a reminder, CLE forms will be emailed to all attendees following the program. The code on your screen will need to be entered and returned. So please copy down this code. It is 03HEALTH23. And please respond to the poll if you wish to receive nursing credit. There will be 3 poll questions in total. Again, the code is 03HEALTH23. I think we're good to introduce our next speaker, Ed.
Excellent. So up next, we have Dr. Evelina Graver, as I said, an attending cardiologist and director of coronary care unit. She completed her internship and residency at North Shore University Hospital, where she also stayed as the chief resident in the internal medicine program. Subsequently completed her cardiology fellowship training at North Shore University Hospital. Dr. Graver is here, and I don't want to eat up too much of what she's going to tell us about, but essentially she faced something that most people, even most medical professionals who weren't at one of the epicenters had to experience during the height of the COVID outbreak in New York. So it was with without further ado, Dr. Graver. Thank you.
Thank you, guys. Thank you, Ed, for the introduction, and thank you, Josh Gager, for having me involved in this program. And I'm actually genuinely excited and pleased to be here. So, just like Ed mentioned, I trained at North Shore University Hospital from the time that I left medical school. I did my internship, my residency, I was a chief resident. I went into my fellowship. I was a chief fellow. And directly straight out of my fellowship was hired as the director of a cardiac care unit. I love being a cardiologist. I love being a critical care cardiologist. A CCU is a place where we take care of all of the patients post-acute heart attacks, post-cardiac arrests, patients with significant heart failure, patients with fatal arrhythmias, which are heart rhythm abnormalities. And that is what I trained in. I went through, as I mentioned, a really prolonged training in that field. And I stayed in one institution because sense of loyalty, sense of stability. And then last year, exactly March 16th, as I was rounding in my unit, and we were getting a whiff of the fact that things are coming and things are coming and things are coming, but they were a little bit slow from what we initially heard. March 16th, I was in the middle of my typical day CCU rounds. Typical morning, I have a huge team consistent of several medical students, interns, residents. I have several nurse practitioners. CCU was at that period of time a total of 18 beds of critical care patients. And like I mentioned, those that are post-heart attacks and the usual cardiac severe complications. So the sickest of the sick cardiac patients. In the middle of my rounds, I was approached by our administration, who pretty much mentioned the fact that, we are currently opening up one unit for the presumed COVID patients that will be coming our way. And Evelina, your unit will be the next unit to potentially be redesignated as a COVID unit, but we don't foresee that happening until much later on in the week, if at all. I genuinely did not even think twice about it, considering the fact that I had a guy in front of me with a cardiac arrest, a guy behind me who continued to have fatal arrhythmias. So kind of gently brushed it off, in all honesty. I think I did that a little bit too prematurely, because at around midnight that night, I was called from administration and was told that, Evelina, your unit is now officially COVID. And all of those cardiac patients that were there before all of a sudden were moved elsewhere. To be honest with you, I still don't know where a lot of those patients ended up going. We started to transfer patients out as quickly as possible to trying to make room for those COVID patients. By the time that I walked in the next morning and started officially running COVID ICU, I already had 11 out of those 18 beds fully preoccupied. And in less than 2 hours, my unit was completely full of COVID patients. The interesting part about it was I kind of quickly got a hang of the administrative side. Is, okay, my unit is now full. The part that I did not get sort of a rundown on is, what do we do with them? And that's where It sounds horrible, but that's where sort of the dart game started in reference to what do we throw in them and what's going to stick. Scary is an understatement in reference to what every single one of us felt because we were not sure. All we knew is the fact that these patients were acutely ill right in front of us. All we knew was the fact that we had to be able to treat them, which we did not know how. We needed to stabilize them. Again, did not know how. And then the thought process became, okay, well, if they're that sick, how in the world do I protect myself as a physician, as a person? How do I protect myself as a mother? Because at the end of the day, I have to go home to a child of mine that actually called me at the time when my unit was actually being pulled and said, Mommy, my school just got canceled. So, as a physician, as a woman, as a mother, as a daughter, everything changed within less than several hours. I was the first one out of my entire department of cardiology to be redeployed into COVID land. Then subsequently, I was the last one to be brought back from COVID land back into cardiology as well. So I'll tackle each one of those facets individually. So as the unit got filled by not even noontime, March 17th, 2020, all we knew at that time is we need to be able to stabilize them as quickly as possible. That's all we knew. How do we stabilize them? Well, if you are classically taught, as we all were, that if somebody's oxygen is rapidly dropping, if you're looking at somebody and you're seeing that no matter how much of oxygen you're adding onto them and you're switching them from nasal cannula, which goes directly into your nose, to a face mask, to then more support, and you realize the fact that their oxygen is rapidly plummeting, the next thing to do is to put them on the ventilator. So during that day, I intubated all 18 patients that were in my unit. The question became, what do I do from that point on? I put them all on ventilators. Some of them actually started to improve as soon as we put them on ventilators. Some still did not improve. Then the phone calls began. What do we do? And the phone calls were amongst all of those that are cardiology trained, right? Because you kind of reach out to those that you've undergone the same training with. You know, did I miss this somewhere in my fellowship? Where do we go from here? And we realized the fact that we were all sort of at a point of, let's try anything that kind of works. So from initial massive phone calls to your cardiology colleagues, then came the calls to all of our intensive colleagues, medical intensive care units, surgical intensive care units, neurosurgical intensive care units. And we were all at a standstill of, let's throw steroids into them as quickly as possible, antibiotics, because all of the chest x-rays that were coming back cannot rule out pneumonia. So what do? Somebody's oxygen is dropping, somebody's chest x-ray is being read as cannot rule out pneumonia. So steroids we go, antibiotics here we go. We have no idea the dose of the steroids, how much of the steroids. Are the steroids going to negatively affect everything else, like their sugar components, their underlying cardiovascular disease? Do they have other features that potentially makes them more high risk for these high dose steroids? We really knew nothing. That first day, and I will never forget that first day, was probably the scariest day of my life. Not the saddest during the time of the COVID, but definitely the scariest. Why scary? Because I realized the fact that I needed to know how to manage my unit, now my new COVID unit, In the place where I've been for the last almost 15 years, from the time that I started my training here till now, and everything was different. I stayed on specifically at North Shore for as long as I did without going anywhere else, simply because of the fact that stability is important to me. Being a single mom, not uprooting my child to go anywhere. And I realized that the place of stability that I knew for the last 15 years was no longer stable. I didn't realize the fact that I could not recognize anyone walking down the hallways anymore, literally after one day, because every single one of us was masked, gowned, with goggles, with shields, with full garbs, and a place where I knew everyone and I could say hello to anyone and everyone, from security to janitors to every single nurse in the hospital and all of my colleagues. All of a sudden, I was completely lost because I could not recognize anyone. So we couldn't recognize anyone. We did not know how to treat these patients. We literally started to reach out, sort of SOS, help anywhere and everywhere. We became the epicenter for Nassau County. North Shore University Hospital has a capacity of approximately 730 beds. At the peak of everything, we had approximately 950 patients. We immediately started building outside facilities to hold some of the COVID patients. And I can tell you honestly, the fact that the care that we were able to provide was the best we possibly could with the resources that we were given at that period of time. And by resources, I don't mean the limitations regarding the N95 masks or surgical masks. Those we've had plenty. What we did not have enough of is the space, is the opportunity to give some of those patients, especially at the end of life, the opportunity to appropriately say goodbye to their loved ones. The reason why I said that the first day was scariest but not the saddest is because the saddest probably was the day that I actually had to say goodbye to my own grandfather, who was in my own unit, who I had to take off of life support myself because of COVID. That was a sad day. Another sad day was when I had to sign 27 death certificates and walk out of the institution after having signed 27 death certificates for those patients that have passed away because of COVID. It frustrates me sometimes when I hear people talk about how COVID may not be real, how unfortunately politics got involved and definitely muddied the picture a little bit for everybody. I can tell you guys the fact that COVID is incredibly real and incredibly scary. And the one thing that I can also say is the fact that the camaraderie that was seen during that period of time in the hospital is something that I have never seen. People were being redeployed from all different venues at a certain period of time in the midst of everything, because some physicians were also getting sick because of the virus as well. At a certain period of time, my team comprised of a dermatology resident and an infectious disease intern who literally barely just started, but everybody looked at her for all of the necessary information. So we had a dermatologist, an infectious disease, a rheumatologist, an orthopedic surgeon as part of the team taking care of these patients. That clearly it was a change, overnight change for every single one of us. How did we do it? We actually stuck to some of the basics regarding, oxygenation and stabilizing them upon upon that. We really put our guard down regarding who knows what, and egos were gone. which was another beautiful thing to see in the hospital, actually. And we had no problem asking for help. And that is the one thing that at times when egos are involved in the hospital, people have a sort of a hard time realizing the fact that and saying, I do not know what I'm doing, please help. I always say it, and I kind of poke fun of it, and said during that period of time, I don't think I've ever said I don't know in that short period of time as much as I did in my whole lifetime. I didn't know. I didn't know what the right thing to do was. I didn't know how to, at the end of the day, call every single family member to let them know the fact that their loved one has passed away. I didn't know the right way of protecting myself appropriately so that I can come home and make sure the fact that I don't infect myself and infect those that are around me. As all of this was happening, I was simultaneously running in semi-ICU in my parents' home because both of my parents got sick March 19th. So at the same time as they got sick, I've now realized after running this COVID unit for the last 2 days straight, probably 18 to 20 hours per day, that getting them into the hospital, most likely at that time, would mean the fact that I would lose both of my parents. So I set up a small little ICU at home and was trying my absolute best with the limited resources that we had at that time to run it. So that was the beginning. I was brought back into cardiology sometime in June. I definitely learned a lot. I actually wrote down some of the things that I learned. So what did I learn during the last year? I learned the fact that, number one, PTSD is a very real diagnosis. Why do I know that for sure? Is because I can tell you after being in COVID ICUs for 4 months straight and being brought to cardiology and things kind of becoming a little bit more laid back and everything else, when we had the second surge and once again, everybody was on heightened alert and we were once again wearing N95 masks in addition to our surgical masks, I had a very hard time putting on my N95 mask, and I still really do. What else did I learn? I learned the fact that ignorance is bliss. Simply because of the fact that knowing as much as I learned from the time of my redeployment, I can tell you that every single time that I hear of somebody getting COVID, including myself recently as well, you only think of the worst. So I always say that ignorance really is bliss. I also learned the fact that life doesn't stop because of COVID, and it shouldn't. Babies are still born. People will still find a way to get married, whether or not it's virtually in person on the moon, whatever, they will get married. And the beauty of COVID is the fact that we can actually all meet in this way. The land of virtual meetings has definitely opened up many opportunities like this one. I think that I'm going to end there and just really thank the virtual world for this opportunity. Thank you. And thank you, Josh, of course.
Thank you very much, Dr. Graver. It's one of those things where you prepare yourself for what you think it's going to sound like, and there really isn't. And it's important, I think, to take a moment to remember, as hard as COVID has been, for a lot of different reasons, for a lot of different things, most of us will never know what it was like to be on the front line and be in the front line during that key time. So thank you again so much for sharing that. And I'll turn it over to Lexi again for just some of the administrative stuff.
Thank you, Dr. Graver, and thank you, Ed. Yes, this is the second poll question, so please be sure to respond if you wish to receive nursing credit. The CLE code on your screen will need to be entered and returned. Please copy down this code. It is 03 Health 23. Again, that is 03 Health 23. And if you wish to receive nursing credit, please respond to the poll. And we'll resume in 1 minute. Okay, Ed, we're good to continue.
And in case I wasn't very good at articulating this, or just it didn't come across, Nassau County, for those of you who aren't New York locals or haven't spent some amount of time up there, it's right on the border of Queens and the outlying county. So it's very much in the mix of New York City. And you know, everyone remembers what at least what the news was telling us things were like a year ago. Up next is Betty McNee. She is a senior clinical risk management consultant in the Graham Company's Safety Services Department. She works with the rapidly expanding Health and Human Services Department as a trusted resource for regulatory and compliance issues, helping clients to improve outcomes and navigate that ever-changing industry. Before joining the Graham Company, she was a member of the senior executive team for Presby's Inspired Life and focused on quality assurance and clinical risk management. In that capacity, she was responsible for ensuring quality outcomes in all areas of senior living operations, including quality of care, regulatory survey performance, corporate compliance, customer satisfaction, and coordination of insurance claims. Betty is going to give us some, enlighten us on issues within the, if Dr. Graver told us about the kind of like the micro level of dealing with COVID front end, Betty's going to talk to us about some of the problems that frankly before COVID were existing within the nursing home industry with regard to availability of staffing, funding issues, and really problems that have only been at a macro level exacerbated by our by the past year. So without further ado, Betty McNee.
Thanks, Ed. I appreciate the intro. And as we talked about looking at how COVID impacted senior care, you really can't even appreciate that unless you look back and see what was going on with nursing homes and senior care prior to COVID. So as Ed mentioned, I work with many health and human services providers, but a good deal of senior care. And, you know, as we look at a total risk management strategy, you have to look at those internal exposures, the things that come out of your own policy procedures, staff education, but also those external pieces, sometimes the things you have no control over, like COVID-19 and societal trends and government funding. All of that comes into play with risk management. So let's go back before COVID. If you can even remember the pre-COVID days, you couldn't flip through an insurance journal without seeing this buzzword of social inflation. And I'm not going to belabor that, but obviously it was this rising insurance claims that was resulting from societal trend and views around litigation. People were more apt to go to pursue litigation. There was this broader definition of what it really meant to be liable, and plaintiff-friendly juries were handing out larger compensatory awards, even these, you heard the word nuclear verdicts, like these, you know, ridiculous numbers for payouts. And they really thought that it was coming out of this anti-corporate sentiment, how much they make, how much I make, there's a huge gap. And people believe that whatever was if anything went wrong, any kind of damage, any kind of hurt, someone needed to pay, even if there was no negligence. And that was kind of fueling all these huge payouts. Of course, boosted by how juries were put together, knowing that depending on how they were composed, that would impact a verdict. Plaintiffs' attorneys really playing this up, advertising, watch TV, go down a major interstate, you see the billboards. So that was going on, but also, you know, that there was this entry of private equity money that was helping plaintiffs' firms basically finance, instead of settling early, going to trial. So you've got this societal trend that predisposes people wanting to, you know, go after the big guy. And now we had money to do that with these private equity firms. More litigation meant these nuclear verdicts, and these private equity firms were going to get a return on their investment. So they would make certain to beef up those claims, however necessary, to make sure that they got one of those nuclear verdicts, if you will. So for the insurance side, we were already dealing with increases in commercial auto, medical malpractice, D&O increases in premiums, and umbrella and excess liability, because that's where those big limits were. Obviously they would beef up a claim to try to get, to those high levels, which we'll talk about in a second. So a simple slip and fall premises liability claim could result in astronomical payouts just compared to a couple of years prior. That was kind of all across the board. But specific to Health and Human Services, we were dealing with two specific things. Carrier exits, a very short list of people who were even interested in writing your business, and these exclusions, dwindling coverages, especially with sexual abuse and molestation exclusions. And in fact, some of the carrier language was excluding not only coverage for a claim that alleged abuse, but not even defense. So, I mean, you were working really hard to try to get verbiage to be able to defend an allegation of abuse. It's very difficult for Health and Human Services providers. So, we talked about this social inflation, everything go into litigation, and private equity people wanting their return on investment. So you would expect any kind of allegation of poor or substandard care in a nursing home would likely and was reinforced with language of neglect and abuse, and add on their corporate greed, so that they're like bolstering these claims to go for those zinger nuclear verdicts. All those factors, social inflation, the nuclear payouts, and the increased litigation altogether, as I said, left senior care providers. There were so many carriers that just left the market altogether, and there was just a very short list of people who were even interested in quoting. And that was very difficult for senior care in general. That was all before COVID. And then COVID-19 comes on the scene a little bit more than a year ago. The current impacts of COVID-19, we'll talk about the litigation landscape, the increasing OSHA, regulatory oversight, penalties, deficiencies, focus surveys, the limits and frankly disappointments in immunity, legal immunity, and getting back to normal. So it seems like plaintiffs' attorneys, our own regulators, OSHA, totally forgot that when COVID-19 came on the scene, we as nursing homes were made to provide a level of care without the basic supplies that were required to care for those residents. The equipment was not available. Alternatives, frankly, were not effective. Before COVID-19, we probably had 2 boxes of N95s. They were under the DON's desk, and we had a couple of people who were fit tested, because the only time we ever needed the respiratory protection program is if somebody developed TB symptoms and we needed to wear a mask long enough for the ambulance to have the person transferred to the hospital. That's the only reason we ever needed it. So that was it. And so this was a huge change. We could not get N95s. We certainly did not have the equipment to do the fit testing. I had administrators who were giving their personal credit card numbers over the phone, hoping for a truck delivery of substitute masks, crossing their fingers that they wouldn't show up on the fake list that came out, every week. We sold the farm for supplies. We paid crazy per diem rates. We used agency, Heck, we even recruited our family to work in the nursing homes to try to care for our residents. Yet in all this crisis, we did care for residents. We took care of one another, and we've nearly made it through. Can we say that we've survived? When can we get back to normal? What is the new normal? What will the future hold? Is there a senior care rainbow? Couple of factors that are going to play into our future, and I'd like to recap them. One is that we are still dealing with increased OSHA oversight and penalties. That continues. Regulators are still having focused surveys and investigations and deficiencies. That continues. And states and OSHA are promising continued scrutiny and penalties. So that's what we're dealing with right now. On the insurance front, we've got carriers that are looking for increased deductibles. They are also looking for increased premiums. They want providers to have more skin in the game. On a completely side note, cyber claims are increasing at exponential rate. And obviously no company, not just senior care, no company is immune. But just so that you know, on that side note, cyber insurance premiums are expected to increase from 25 to 40%. But with all of your other lines of coverage, on the insurance front, much more scrutiny with all of the renewals, really digging in on policy and procedures, working a lot to make certain that all of my clients are implementing best practices, evidence-based research in all of their policy and procedures so that we can get them that best rate. Of course, all publicly reported information is being used in that underwriting process. So that is another thing to manage. All insurance policies going forward are expected to have some sort of a pandemic exclusion. I promise I will get to one piece of good news, but anyway, let's keep on with this list of things to consider. As far as litigation, do you guys remember when there was this hint of immunity? Maybe if as the doctors were speaking of doctors that came out of their area of expertise, there is some professional immunity, but for senior care providers in general, the immunity that we had hoped to get is really not panning out to be so. And it's rather disappointing. It's like people, forgot we were doing the best that we could. Everybody's facing low occupancy issues. People are reluctant still to move into skilled nursing. One of the things you need to consider when you're trying to recover from COVID-19 is being very careful not to bend your admission rules. Carriers have their antenna up. They're ready for what's called acuity creep, where you'll bend your rules and take in people that you wouldn't have otherwise admitted. And it's a perfect storm for a liability exposure. So be careful. If you do flex and need to make changes in who moves in, then make sure you're doing your policy procedures and your staff education so that you don't increase your liability. In general, census are down 60 to 70% is what we're seeing. We know that nursing homes get into financial trouble if they're around 80%. So that's obviously concerning. People are staying in assisted living. Maybe if they were in a continuum already, they're staying in assisted living. We've seen this increase of acuity in assisted living over the last couple of years. If that continues, which it looks like it will, there's a great possibility that higher acuity in assisted living is going to deteriorate that insurance market. Unfortunately, so the premium increases we saw where they were asking for premium increases, 80% of the nursing home bed may actually increase even further than that. And I have also seen some for-profits that were downsizing their SNF beds altogether. So that's something that may come of the post COVID days. People that watch the industry say that the staff that left will likely not be back. We've called them back. Folks that just exited somewhere in COVID has left a big hole there. However, you may see some people that worked in acute care that want to transition to like a home and community-based service, anything to get out of that institutional setting. So that may be a plus. One little bit of good news is that obviously federal regulations are easing up. We're having some welcome back reunions and some parties. And one of the good things I've seen, and I hope it does continue, is that staff and families kind of almost commiserating together, finally being able to be together and come together and be together. It seems that when families see the faces of the people that were there a year prior and that they're there and they didn't leave, that perhaps there is a gratitude or a respect, an appreciation that wasn't there before. That would be nice to continue. But with all of these factors, the greatest impact for the future of senior care is going to depend on what changes are coming with Medicare, Medicaid, managed care, healthcare reform in general, any kind of reimbursement change. That is going to really kind of shape things for the future. But that's a big financial factor, but those aren't the only financial factors. In the post-COVID world, you have to think about infection control things like, will there be shared rooms? Will anybody, be interested in going to a shared room? Will the nursing homes have to close that second, go full private, and lose the income for that second bed? There are a lot of demands for increased staffing levels. So, financially, how is that going to pan out? And one other, nursing assistants, the frontline caregivers make on average $12 to $13 an hour. How is a nursing home going to compete if the minimum wage is raised to $15 an hour? Something to think about. So we shall wait and see what the future is for skilled nursing in the post-COVID. But in summary, this storm has been brewing for some time. We will likely not get back to the way things were, but that's okay, because the one thing we can appreciate is how this crisis honed our commitment to caring for people. And for all of us that endured this crisis, the resilient ones, you on this MEDx Talk, you will be the ones that reshape our industry. You'll be the ones that allay the fears of the seniors and their families and rebuild customer and consumer confidence in senior care. You'll be the ones that are going to adapt your service offerings, more daycare, more home and community, more telehealth, whatever that looks like. You'll be the ones that will respond to what consumers are asking. Because the baby boomers are right there on your doorstep. And they're ready to have confidence again in what we're doing in senior care. Maybe it looks a little different. So responding to their needs and preferences will help to reshape. And besides, just think of the story you will have. You can tell the story of the good old pre-COVID-19 days, and then you could tell the story of the actual COVID-19 crisis, of everything that we dealt with. And then you'll have the story of the new, improved, and revolutionized post-COVID days. Thank you, White and Williams.
Thank you so much, Betty. That was simultaneously, leveling in terms of understanding the process we have to do, but inspiring in terms of that there are ways to fix these issues and to hopefully care for the next generation. So thank you again and so much, and to all of our speakers. This has just been, you plan these things and you have an idea how they're going to go. And one of the themes of MEDx has been is that it always just year for year it exceeds our expectations, and this format just lends itself to really, I think, sparking the thought processes and our imaginations and helping us think about things that we haven't thought about before. So for one last time today, I'll turn it over to Lexi to go over the nursing and CLE credits questions.
Thank you, Betty. Thank you, Ed. Please copy down this code. It is 03Health23. And as a reminder, please respond to the poll if you wish to receive nursing credit. This is the last of the polling questions, so please make sure you respond if you wish to receive credits. And I'll leave it up for another minute before Ed will take us into our Q&A. If you have a question for our speakers, I now encourage you to send it through the Q&A tab, and Ed would then be able to go through.
Sure. I can probably kick it off with a question I have for Dr. Graver. Is one of the things that I've heard, kind of being bandied about in the idea that these variants are going to potentially give us another surge in hospitalizations, but to the extent that there's a bright side of that we're, doctors, hospitals are getting better at taking care of people that come in. So I guess maybe, if I'm calling it free to speculate, I certainly don't mean to do that, but do you see that there'll be, if there is what we'll call it a third wave or the first one never really ended and this is a second wave, do you see that the outcomes will be better?
So I can tell you, Ed, where, the way that I kind of mentioned it in the beginning, where when we literally just started, it was playing like a darts, right? Just throwing and seeing what sticks and everything else. At this period of time, we actually have a kind of a definitive protocol. It's not definitive because it's changing, but we actually do have protocols, and based upon everything that we've seen over the last year, from research and experience as to what we can do. So do I see an improvement? Absolutely. Do I see a lot of people that potentially would have passed away last March walking out of the hospital this March? Absolutely. I literally just had an 83-year-old patient that came in and who was significantly desatting with his oxygen in the low 80s, that probably last March I would have put already on the ventilator, that I did not. We were able to treat him appropriately with a high dose steroids. So we now know the actual dose to use of the steroids, how often to use it per day, and for how long. We also have remdesivir, which is an antiviral regimen that we do that have shown significant amount of improvement. I did not need to put this patient on the ventilator, and he's actually going to be discharged tomorrow. So yes, we do see certain things. And we also know the fact that not every single COVID patient needs to be hospitalized. Not every single COVID patient, like I mentioned, needs to be put on the ventilator. We're able to do a lot of things for patients now on the outpatient side, also based upon their symptoms, right? With the monoclonal antibodies that we did not have at that period of time as well, with use of famotidine, which is a Pepcid, which we also did not even think potentially could be of use back last March and April. So we're at a not as lost state of mind as we were last year. So, and I'm hoping that because of that knowledge, we're definitely going to have a bit of a better outcomes. Now, what you mentioned regarding whether or not the knowledge that we have right now, can that be further extrapolated to the new variants? from what we understand, that should not change. The only thing that we know about the variants right now is the transmission is a lot more rampant. But sort of from the presentation and its effect on the respiratory system, cardiovascular, hematological system are still the same.
Thank you. That was about as direct an answer as and give us something that by its nature, we're still studying and trying to figure out. So I really appreciate that. We have another question for this one was emailed to me for Dr. Newman. With the telehealth has grown exponentially, I would because of necessity of COVID, and I guess trying to figure out how to phrase this question. With people vaccinated and hopefully a return to more normal life, do you see telehealth? This is the question: is it good enough that for whatever cost savings that would come along with it, and frankly probably time savings too, number of patients you can see in a day? Do you see it, I guess, sticking around, for lack of a better word? And from whatever studies may have been done during this 1 year, is there a significant trade-off in quality of care that comes with telehealth?
Thank you for that question. Next question. I want to take just a moment, if I could, do something I've never done before, and that's to thank profusely one of my co-panelists, Dr. Graver, for sharing her story. It was absolutely amazing. I was filled with horror at what you endured, respect for what you accomplished, amazement at your resilience and empathy as a provider and a fellow human being. So thank you so much.
Thank you.
That will last with all of us for many, many years to come. So thank you for that. In terms of telehealth, it's been an interesting, journey with both. Whoops, I think I unvideoed myself. With both Ask a Doc and telehealth, both of which were sort of catalyzed to some extent with the pandemic. We definitely saw a bump in use of Ask a Doc, and our system did an amazing job of turning on tele video, which prior to COVID was a couple of percent at the most. And literally within 72 hours, they had us on a fully vetted system. And it was really almost the standard of care at the initial onset, when we really had to, not see people for the most part at all, except for utter emergencies in the outpatient setting. And so it's always interesting to me what things trigger, these kinds of changes. And it's just, a shame that it has to be an absolute crisis for some things to actually get over that hump. But it's been interesting. So, we moved from, a telehealth here being almost 100% to what I would call sort of a level set as the pandemic we started to see things get a little bit under control, where we were probably about 20% face-to-face, 80% telehealth. And now we're at 50, 70% face-to-face and 30% telehealth. So, this hole that opened up for us in terms that we started to move towards of, the future of medicine being remote, is now starting to close again. And so I think a little bit is, a little bit Sisyphusian, where the rock's kind of rolling up the hill and then sort of rolling back down again. So I would predict that telehealth will be a force to come, but probably not at the level it was as it was catalyzed with the pandemic. And part of that, I think, is a few factors. One is, I think, to some extent, patients miss seeing their providers. At least for us as chronic disease physicians, we have established relationships with people for decades. And while us doing this is nice in the video audio, there's so much you lose with not being able to be there in person, the facial cues, the warmth, whatever, even the touch, of a physical exam. And so I think some of our patients have said, I really would like to see you face to face again if we were able to do that. So I think that's one driver driving it down. I think in terms of how well it works, for issues where a in-depth physical exam is not required, which it depends on your specialty. In cardiology, if you're an interventional cardiologist, it may be a very small part of what you do. For rheumatologists, it's a big part of what you do. So there's a lot we can accomplish with our patients through telemedicine. But if you do need that, physical exam piece, then telemedicine just does not help. And the other unfortunate thing for a lot of the telemedicine we were doing, it really wasn't what we had done traditionally, which was me in my office with a nice camera and the patient in a primary care office with a $10,000 telemedicine cart with a high-end, video. It was really their, $65 Amazon camera and not very good bandwidth. And so even things like looking at a set of joints becomes very challenging. Things that could still be visual, you should be able to see with a camera. Unless you've got a good setup, it's really really not as good. So I don't think care suffered if you compare with what care would have been like if we hadn't seen you. But I think we're starting to see some level setting of, COVID can't see you. This is what we have to do. We're either going to talk to you by phone, we're going to see you through a camera. But now I think we're starting to level set a little bit more about what kind of patients can we see at home with not a very good camera connection versus who do we really need to see face to face. So a long answer to a very short question, but hopefully that helped address it.
No, that's exactly what I was. That was the question. So thank you. Just for a question for Betty, what is the status of visitation in senior facilities, and how is vaccination impacting on it? I guess from a macro standpoint.
I am trying to turn my camera on, but hopefully you can hear me while I'm trying to push the button. Oh, good. There are changes in CMS allowing some, depending on the incidence rate at a community, allowing or loosening up visitations. The neatest thing on this is that this has helped to promote vaccination with staff, because for instance, and with family members as well. So people that might have been on the fence about being vaccinated now realize that some of the benefits are being able to go visit that loved one in the nursing or assisted living setting, and potentially having the person at their home without being quarantined for 14 days back to their room. So that's been a huge positive. On another kind of side with vaccination that I think has been a big plus is that as some of the required post-travel quarantine rules are coming off, and some of the rules with when someone's fully vaccinated, that they're not subject to some of those things, that has also served as an incentive for people to really look at vaccination. So that really, I believe we're gonna, those rules are changing all of the time, and they're all positives to getting back to that new normal.
Excellent. And then there's one, this will probably take us out, question for Dr. Graver. Given your experience with treating COVID over the past year, have you reached any conclusions on why some patients did well with treatment and some patients did not respond? Also, the person just wanted to say thank you for sharing your compelling experience with us. And I'm sure your patients and families are grateful for what they've done. So the question is, any conclusions on why some patients did better than others?
So to tell you honestly, I know that there's been a lot of literature published regarding potentially age greater than 65 that did not do well. Male sex, I'm sorry guys that are on the call, you are at a higher risk than women. Thank God for estrogen, it still has some good utility for us. To tell you honestly, when I would leave the unit in last March or April, and everybody was saying we have nothing to worry, it's the disease of the elderly, and I would come back into the unit the next day and there was a 20-year-old and a 30-year-old and a 40-year-old who's on a ventilator. It's hard to say. What we do know based upon the literature so far and all of the research is the fact that those that are at high risk are those that are 65 years of age and older, those that have predisposing conditions, those that have anything that potentially can deem them being immunocompromised. Unfortunately, obesity and being overweight is also a significant, completely independent risk factor from what we've seen, especially in the youngsters. Those 20 and 30-year-olds that I mentioned just now, the only thing that some of them had was underlying overweight and obesity. And COVID didn't kind of help with this because COVID made people more sedentary, and that caused them to gain more weight. Stress caused them to go up in weight, and they became more predisposed to COVID. So it became like a vicious cycle a little bit. But those that actually did well seem to have been on the younger side, those that had minimal risk factors, and those that did not actually come in late in the game. And that's the other component that I really want to make very clear is that at times a lot of people were and still are incredibly so scared to come to the hospital because of COVID that they delayed their presentation and the possible treatment. And right now that we actually do have some degree of treatment, if people are getting sick, do not delay. Do not get to the point where you are in that atrocious inflammatory cascade, cytokine cascade, and you're past the point where we can actually truly help at this point.
Well, thank you very much for that answer. Thank you very much to all of our speakers for taking the time to be with us. If anyone has any particular follow-up questions or ideas they want to share with their speakers, I can pass anything along. If they want to find me, my email's out there on the internet. Again, I certainly wish we were there this is normally when we're beginning our cocktail hour portion of the event. So, to the extent that if you have any in your home, feel, I encourage you to kick back, relax, try to enjoy some of this nice weather. And I certainly hope to see you all in person the next time we do this. Although the plan for the remainder of the year is to have one or two more of these events with a panel of speakers. And you'll be just follow your emails inboxes, and we'll send you what we got when we know about it. So you all take care, and thank you again.
Thank you.